Hi everyone, thanks for listening to all my presentations. Today I'll be talking about liver failure, but I'll be limiting myself to symptoms, causes, diagnosis, and differential diagnosis of liver failure today. By definition, acute liver failure means that there's development of acute liver injury with encephalopathy, and there is decreased synthetic function evident by INR greater than 1.5 in an individual without liver cirrhosis or liver disease. It's either you get the value of INR or PT, it's the same. And when the value of INR is getting higher and higher, then you are getting closer and closer to bleeding. When the value is dropping lower and lower, then you are getting closer and closer to clot or clot formation. In case of chronic liver disease, that will start with illness that is already greater than 26 weeks. So it's a function of time when it comes to chronic liver disease. When acute liver failure is not corrected or is not handled or we couldn't get out of it and we are getting to 26 weeks, we are already in chronic liver disease. Acute liver failure will remain the definition when the liver disease is less than 26 weeks. Even if it is 24 or 25 weeks, it's still acute. It's still acute liver failure. Then we're going to find that in Wilson disease previously undiagnosed. If you want to know more about Wilson disease, you can check my channel for that. I have a separate full presentation on Wilson disease. It could be in acute severe alcoholic hepatitis. Will also be found in hepatitis B that has been vertically transmitted, in autoimmune hepatitis, or in acute or chronic liver failure that is diagnosed in severe acute alcoholic hepatitis. Know this. It's possible we'll be dealing with upper acute liver failure if it is less than 7 days. It will remain acute in 7 to 21 days and subacute in 21 days to 26 weeks. After that, it's chronic liver failure. Causes of liver failure. Viral and drugs are the most problems. Part of the drugs will be acetaminophen, and part of the virus will be hepatitis A, autoimmune hepatitis, adenovirus. If you go by B, the Budd Chiari syndrome or hepatitis B, C will be covering for cytomegalovirus, hepatitis C, cryptogenic causes of liver failure or chemotherapy with hepatitis B virus reactivation. D will be for hepatitis D and drugs. E for Epstein-Barr virus or hepatitis E. Acute fatty liver or pregnancy could be responsible, and of course genetic problem as it could be found in Wilson disease. I have published full presentations on hepatitis A, B, C, D, and E right here. So you can check my channel for how they are transmitted, the clinical features, even the laboratory diagnosis and treatment of all of them. Still on causes of liver failure, it could be HELLP syndrome. That is hemolysis, elevated liver enzymes, and low platelets. I have published a separate presentation on HELLP syndrome right here. You can check my channel for that. It could be hypoperfusion, herpes simplex virus, heat stroke, hepatectomy, Hemophagocytic lymph-histiocytosis, infiltration tumor or ischemic hepatitis, Reye syndrome, immunocompromised with herpes zoster, toxins like mushroom poisoning, and sepsis. What are the possible clinical features of liver failure, hepatic encephalopathy, on account of which we'll be using rifaximin and lactulose. There's a separate presentation here on lactulose. You can check my channel for that. Prolonged protein time with INR greater than 1.5, jaundice, hepatomegaly. I've published some presentations on jaundice. You can check my channel here, and also differential diagnosis of hepatomegaly. Right overchondral tenderness, fatigue, malaise, lethargy, and anorexia. Part of the clinical features will include nausea and vomiting, pruritus, ascites evident by abdominal distension, confusion, coma, increase in the cranial pressure with pupillary changes, and hypertension. Still part of the symptoms or clinical features will be bradycardia, respiratory depression, seizures, abnormal brainstem reflexes, vesicular skin lesions like herpes simplex, fever, and orthostatic hypotension. Now, how do we make the diagnosis here? Thorough history, thorough physical examination, then we add to lab. On getting to lab, what's our business? We want to know what liver function test is telling us. And with that, we want to know the level of bilirubin. Glucose or glycogen storage level, we want to know that. What is albumin level? How about alpha-1 antitrypsin? What is INR or PT? The value of APTT, we want to know. Because INR or PT, APTT is necessary because all clotting factors are produced in the liver except two. And those two will be von Willebrand factor and factor 8. Then we want to know what's happening to liver enzymes. AST, ALT, GGT, ALP. Complete blood count, toxicology with acetaminophen level and other drugs that could affect liver adversely. We will check for beta-human chorionic gonadotrophin in all women of childbearing age. Why that? You can supply the answer. You can't? You know it. All women of childbearing age is always the wisest thing to do to know if they're pregnant or not. Because you can't just jab them with any medication, right? And interventions will be restricted based on the age of the pregnancy. You don't want that woman to lose the precious gift, right? Okay. Still part of diagnosis will be hepatitis serology. I will not waste my time going over all these right here because you can check my channel for all of them. Hepatitis A, B, C, D, and E. I have full presentations on all of them already published here. So you can pause to look at this, but if you really want to go in depth, check my channel for all these, pieces of info. They're already published right here. Autoimmune markers, ANA, anti-SMA, rheumatoid factors, immunoglobulins, we can assay them because we might be dealing with autoimmune hepatitis, right? Arterial blood gas, arterial lactate, and arterial ammonia. We can have HIV screening done, lipase and amylase because the pancreas might have been affected, and of course, ceruloplasmin level when we are wondering if this is wheezing disease or not, because ceruloplasmin level will be low in wheezing disease, and they will be on penicillamine for life. We can have urinalysis for proteinuria in case we are suspecting HELLP syndrome. Like I've said, I have a separate presentation on HELLP syndrome already published right here. We can have radiological investigations done, either to back what we are suspecting based on history, physical examination, and laboratory values, or to make a definitive diagnosis having liver biopsy. So we can start from the cheapest one, and that will be readily available, like ultrasound, then CT scan, magnetic resonance imaging, and if our center is highly sophisticated, we can have magnetic resonance venography. And of course, we have liver biopsy done. Differential diagnosis. It might be severe acute hepatitis. Could be alcoholic hepatitis. This might be acetaminophen toxicity. That's why I said thorough history, thorough physical examination. If this is a young man and now having dementia, could be wheezing disease, just check my channel for full details as per wheezing disease. And it might be hepatic encephalopathy. And with that, I've come to the end of this very presentation. The next presentation will be on how to treat liver failure. Okay, remember to leave your comments. Remember to share this presentation. Remember to subscribe to my channel so that you can get all my presentations immediately they are published. I appreciate it.